Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Adil Fatma from Mayo Hospital, Lahore. Today I will share with all of you a journey of tears, fears, hope and faith. The copyright of this presentation belongs to Dr. Shabana Chaudhary. By the end of this presentation, we will be able to update our knowledge in the recent advances of retinoblastoma and share information about available treatments in tertiary care hospitals in Pakistan. So the story began when a 9-year-old girl was brought by her mother in the OPD with a complaint of pain and whitish lesion in the right eye for 3 weeks. The patient was the only child and was born after 9 years of non-consanguineous marriage. On ocular examination, the right eye had visual acuity of 624, IOP of 41 millimeters of mercury. The anterior segment had hypopyon, AC cells, and white fluffy exudates on iris. The left eye examination was unremarkable. The B scan showed infrared hemorrhage and exudate with fluffy lump at supratemporal peripheral retina. There were no signs of intraocular calcification. So according to our departmental SOPs, we started the management of this case as retinoblastoma suspect, according to the National RB Guidelines of 2018. So baseline UA was done that reinforced the findings of anterior segment. The fundus showed infratemporal lesion and plaque-like lesion superiorly. The macula was uninvolved. So the bilateral fundus view at the time of the first UA was this. So what differential comes to your mind? Okay, let's move forward. The differential that we made was of inflammatory etiology like uveitis, infectious like toxoplasmosis, neoplastic, but the common pediatric masqueraders are retinoblastoma, Coats disease, juvenile xanthogranuloma, and posterior uveitis. The dilemma in the diagnosis of this case was the age of the presentation, which was 9 years old, which falls out of the category of retinoblastoma. Visual acuity of 618, no signs of calcification on B-scan, and unremarkable systemic examination. So further diagnostic procedures and ocular imaging was done that would differentiate between the uveitis and retinoblastoma. Meanwhile, treating on the line of the inflammatory disease, PST Kenacort was given on first EUA, and Equostab was sent for the LDH level that came out to be raised. MRI was done that showed the impression of N-plaque retinoblastoma with uninvolved optic nerve. So the definitive diagnosis of retinoblastoma of diffuse subtype was made that manifested as devastating uveitic masquerade. According to IIRC and ICRD, this case fell into the category of group E. And for unilateral group E, primary enucleation is the treatment of choice. But the recent advances have allowed us to offer globe-saving treatments like intra-arterial chemotherapy and intravitreal chemotherapy. Extensive counseling of parents was done. Parents refused enucleation and opted for intravitreal and systemic chemotherapy. So intravitreal chemotherapy was started with 0.03 mg melphalan in 0.1 ml, given 3.5 ml away from the limbus. After the needle is removed, triple freeze-thaw cryotherapy is applied to prevent the needle crack sealing. 0.5 ml melphalan was also given intracameral and subconjunctival. So there were 4 intravitreal, 2 intracameral, and 2 subconjunctival melphalan on 2 to 3 weekly basis, along with the focal therapy. The systemic chemotherapy of the patient was managed by pediatric oncology, and 6 cycles of vincristine, etoposide, and carboplatin were given. This is the photographic journey of the patient after first and second intravitreal chemotherapy. Following the treatment, type 3 regression pattern was noted. This is the status of the patient as per November 2022, with descriptive visual acuity of 612, stable MRI, and bone scan with the normal limits. This is the fundus view and the peripheral fundus view. So the treatment for retinoblastoma are trending towards targeted primary therapy with selective intra-arterial and intravitreal chemotherapy, which has shown as a promise as a treatment. Thank you. But the journey for this patient does not end here. She will have lifelong follow-up for reoccurrences and secondary tumors. Thanks.
House is open for questions.
Sorry. Any questions?
Okay, how many injections of melphalan you have given?
4 intravitreal, 2 subconjunctival, and 2
So I had a 50-year-old female presented me in the outpatient department emergently with sudden onset redness and blurring of vision in her right eye. There was no inciting event, and the complaint was from the last 3 days before she presented. She describes the blurring of vision as shadows and halos around light. There was no known association except that there was a headache, and she described a little periocular pain. She went to a local clinic for initial management, and at the time she said a topical installation made her condition much worse, worsening her headache and causing nausea. She was referred to us for further management. The patient had had history of transient attacks of blurring in both her eyes for the past 6 to 8 months. She never took any treatment for the problem. She's never used any refractive corrections. She had no history of ocular surgery, trauma, injections, or laser to her eyes. She was a healthy female, and her family members did not suffer from similar or other ocular conditions. The patient was a housewife, a non-addict, and she described that she was from a lower socioeconomic strata. On the initial examination, her vision was 636 in the right eye. The intraocular pressure was 60 millimeters of mercury with a Goldman inclination tonometer. The pupil of this eye was mid-dilated and sluggish. On slit lamp examination, the conjunctiva was violaceous in appearance. The cornea had some microcystic edema. The anterior chamber was quite narrow, the one hair was 1, and there was pigmentation seen on the endothelium. The iris had a little atrophy in the anterior part of the lens, there was some opacity seen. The cup disc ratio was 0.75 in this eye, and otherwise the posterior segment was normal. Similar examination on the left eye only showed that there was again narrow angles in this eye. On gonioscopy, I found that in 3 quadrants no angle structures were visible, and in the right eye there was pigment smudging seen. Emergently, we gave the patient intravenous mannitol after ruling out any contraindications. It was given slowly over an hour. The patient was sent home with Diamox 4 times daily, 250 milligrams, and potassium supplement, painkillers, and a regimen of anti-glaucoma therapy. After 3 days, the patient's vision had come to 624. Her pressure was 32 millimeters of mercury. We carried out central corneal thickness. It was 505 and 506 micrometers. On confrontation, the visual field of the right eye was somewhat reduced in the superior-temporal quadrants. I carried out some investigations, including visual fields by the Humphrey field analyzer. In the right eye, there was reduction in sensitivity superiorly and laterally. I performed an indirect non-indentation gonioscopy. As you can see in this, there are no angle structures visible in any quadrant. Superiorly, there is some pigment seen, but I would like to warn you that this is not the meshwork. This is a video of the superior quadrant. As you can see, as I move the light or I move the lens towards one side, the pigment that you see is in fact smudging. It is not the meshwork. So it gave me an idea that there had been intermittent attacks in the past. Posterior indentation gonioscopy was performed, and again, there was appositional angle closure. Osteoretinal nerve fiber layer was followed with OCT anterior segment. I could see that the pupillary margins of both the eyes were well opposed with the lens, and the angles showed crowding. So both mechanism of angle closure was at play here. We decided to go for phacoemulsification with posterior chamber intraocular lens implantation. We took an informed consent, and the senior most surgeon available performed the surgery. Post-operatively, happy to say, the results were brilliant. The cornea had cleared up, the pupil was round, regular, reactive. The patient's vision was 618. Her pressure had come down to 17 millimeters of mercury. Here, we decided to shift the patient to a monotherapy, and we performed an OCT anterior segment again. The pupillary block had completely relieved, the angle had opened up, and as you can see, 1 week after surgery, the pressure was down to 12 millimeters of mercury. On the lines of this particular patient, we did a few more patients, and we followed the same treatment plan. Between August 2021 and February 2022, you can see that there is a drastic drop in the intraocular pressure. These patients began their journey with a multi-drug regimen and they were brought down to mono or no therapy at all. I would like to conclude here that frequent emulsification in patients who are predisposed to anti-closure or have anti-closure glaucoma can prove to be a stitch in time. It not only improves the quality of life, reduces disease morbidity, and it also reduces the load on hospitals that are managing those patients. That is all from me. I thank you.
Questions regarding this talk? Dr. Khalid?
What happens when you do the figure emulsification? What happens actually to leaves?
Yes?
You do the figure emulsification.
Yes.
So what was? Did you have any other option for this?
Yes. The other line of management is spectral iridotomy. And we decided to avoid that, and we decided to go for a fig instead.
And what was the age of the patient?
The patient was 50 years old.
50 years old.
Yes.
So anyone beyond prosopagmic age, you can go with the figure emulsification spectrum.
Yes.
Fine.
Okay, now we move forward.
Thank you.
Thank you very much, Dr. Sara. And is Dr. Asfa Farooq here? Okay. And now she will come to deliver a talk on dermolipoma. Dr. Asfa Farooq.
Assalamualaikum. My name is Dr. Asfa Farooq. I am a second year resident in the discipline of MS Ophthalmology at Sir Ganga Ram Hospital, Lahore. Moving over to the case presentation, we had a 3-year-old boy resident of Nankana Sahab who presented to us in OPD on 2nd November 2021 with a presenting complaint of swelling in the left eye temporally since birth. Initially, the swelling was small, but gradually it increased in size. It was not associated with any redness, discharge, or disturbance, but it was associated with difficulty in completely closing the eye. He was a full-term baby born by C-section. There was no history of any incubation or delayed cry, but he was having history of delayed developmental milestones, like he started having neck pulling at the age of 6 months, he started walking at the age of 2 years, and even at the age of 3 years, he was not able to speak properly. His past medical and surgical history was not significant. His parents were having consensual marriage. His father was a smoker. There was no history of maternal diabetes or hypertension. All other siblings, they were normal. While doing the general physical examination, the little boy was sitting comfortably in chair and he was playful. He was having preauricular tags on both sides and there was a facial asymmetry noted more on the left side. No other hearing difficulty or spine deformity was noted and all of the general physical examination was normal. While doing the ocular examination, there was a prominent swelling of approximately 3 to 3 centimeters in the left eye near the lateral canthus approaching near to the limbus. It was soft to firm in consistency. The part of the conjunctiva was keratinized and it was mobile with the eye movements. A small swelling was also noted near the right lateral canthus. Bilaterally, the lateral canthus they were not completely developed. This picture is being shared with the consent of his parents. You can clearly appreciate the preauricular tags in this picture. Among investigations, we performed all the BS signs which were normal. Moreover, CT scan orbit and brain, it was done to rule out any extension. CT scan report, it was also suggestive of a large fatty mass at the left side of the left eye and there was no orbital of the brain extension was noted. Among differential diagnoses, we made Golden Heart syndrome, Treacher-Cullen syndrome, Townes-Brocks syndrome and Chart syndrome. After ruling out all others on the basis of the history and the detailed examination, we made the definitive diagnosis of Golden Heart syndrome associated with dermolipoma. Here is just a brief review of what is Golden Heart syndrome. This syndrome is basically characterized by the craniofacial anomalies associated with the vertebral, cardiac, renal and central nervous system defects. It is characterized by a triad of anomalies comprising of abibulbar dermoids, accessory auricular appendages and oral fistula. Our management plan was to do the surgical debulking of dermolipoma and to get the systemic evaluation of the child done from the pediatrics and the ENT department. It was done and it was all normal. Now I will show you just a brief clip of the surgical procedure. First of all, when it was given at the junction of the keratinized and the non-keratinized part of the conjunctiva, then the plane was made with a blunt dissection to separate the underlying vascularized fatty tissue from the overlying conjunctiva. Some surgeons they prefer to first hook the lateral rectus muscle during this blood dissection procedure, while others, depending on the expertise, they skip this step and just proceed with a careful dissection. As far as our post-grad level is concerned, we must preferably first hook the muscle before proceeding. Then the supromedial extension of the mass, it was cut. And likewise the intromedial extension of the mass, it was cut. Then the root of the mass, it was clamped as it's a highly vascularized tissue, and then it was cut. The rest of the stump, it was allowed to retract back behind the conjunctiva. The rest of the conjunctiva, it was approximated with Vitral 60 interrupted sutures. One of our main concerns during such procedures is to save the conjunctiva as much as possible so that it will not result in the restricted eye movements later on. Moreover, it will also give a better cosmesis. In the end, the eye movements, they were checked in all the directions and they were full. The collected specimen was also sent for the histopathology report, which was also suggestive of dermolipoma. This is a post-op picture at the 0 post-op date. This is a post-op picture after 1 week. You can clearly appreciate the left-sided minor hypoplasia here. Just for the better comparison purpose, pre and the post-op picture together. Here is another pre and the post-op picture. In that, on a lighter note, though we have removed such a large mass for the better cosmesis of the child, but still we could not take his angry looks away. Thank you.
Any question? Okay, how do you check if you check the extraocular movements per op? If there is any problem with the muscle, how will you know?
If there is already any restricted movement,
Per op. You showed that you moved it on both sides, but how do you know that if it is cut or not? Because you have just moved it from one side to the other.
so if the lateral muscle it will be compromised, then definitely there will be esotropia.
No, per op.
During surgery, patient is respiratory under anesthesia,
These are the
cannot present but how do you, when you have done with the process, how do you know that it is restricted? Okay.
Okay, there is no resistance you cannot feel, but it is after post-surgical use. It's most important. Okay, now we move over to Amina Latif. Is she here? Okay. Glaucomatous, polyangiitis, and its ocular complication.
Assalamualaikum. My name is Dr. Amina Latif, and today I am going to present about a patient which came in our department. He is a 45 years old male resident of Chiniot, referred from the rheumatology department with complaints of decrease of vision in his right eye. Patient is a known case of granulomatous polyangiitis and has been on intermittent treatment since 2016. Now he presented with decrease of vision, redness, discomfort in his right eye. The past ocular history showed that in 2016, as he was diagnosed with granulomatous polyangiitis, for which he was on intermittent treatment with relapsing and remission, in 2017, he started developing a nodular scleritis in his left eye, which ultimately led to scleromalacia perforans, for which he got different treatments from various hospitals. Cataract extraction surgery was done in the both eyes, and there was no history of significant lasers, trauma, or fever. He was a known case of diabetes mellitus and hypertension since March 2022. And mastectomy in the right ear was done in 2016. As the patient was admitted under the Department of Rheumatology, so currently he was on this treatment. He is married and belongs to a low socioeconomic status. On ocular examination, the gross inspection showed that there was a slight sagging in the central part of the right lower lid ahead to the area of the staphloma, and a mild disparity showing a small palpebral aperture of the left eye. And in the same eye, in the left eye, we have seen that there was S-shaped deformity. On palpation, the orbital margins were intact, there was no palpebral mass, soft tissue or any bony defects. Pulsation and breathe were not detectable. Thyroid examination was not remarkable, and there was not any lymphadenopathy was seen. So as we can see, this is the picture of the right eye of the patient, and this is the slight sagging of the right lower lid ahead to the area of the staphloma, and this is the left eye. On further ocular examination, the visual acuity in the right eye was 6/9, but it was counting finger in the left eye. There was no improvement with pinhole or BCVA. The intraocular pressure was 12 mm mercury into both eye. The color visions of the right eye was 12/15, and left eye only gross colors were appreciated. The extraocular muscle movement in the right eye was smooth, accurate, full and equal, but there was a limited upward and lateral direction, there was limitation in the left eye with upward and lateral direction with no diplopia. The brightness sensitivity test was not appreciated. The lens in the both eyes actually was inferiorly displaced, but it was more in the right eye. Sclera of the right eye showed that there is thinning near the limbus without a vascular condition from 6 o'clock to 8 o'clock position in the right eye, but in the left eye there is a melted sclera exposure with the underlying uvea from 11 o'clock to 3 o'clock position. Both fundi of the patient showed that the right fundus there was a pinkish pale disc with dull foveal reflex, and in the left eye there was healthy disc margins and some epiretinal membrane and vitreous band extending between the optic disc and the macula. So this is the images of the right eye, and in the left eye we can see in the second picture, there is some sutures of already done amniotic membrane graft. This is the fundus picture of the both eyes. The B-scan was normal, and there was a loss of foveal control in the left eye with epiretinal membrane. The systemic investigations were done, which showed that there was +3 glucose and ketones, and also the CT-PNS showed bilateral erosion of the paranasal sinuses, and that chest HRCT, a thin fibrotic nodule in the right lower lobe adjacent to the right hemidiaphragm. MRI brain and paranasal sinuses were done, which is suggestive for sinusitis, and there was adjacent soft tissue, extension of the adjacent soft tissue orbit in the intercranial and with the meningeal involvement. As we can see in this picture, there is erosion of the right and there was erosion of the maxillary sinus and with extracorneal involvement. So the treatment option we thought for this patient in the right eye is to observe and conservatively manage the patient and IOL repositioning or replacement, and in the left eye we can do the redo of the amniotic membrane grafting and scleral patch grafting. So currently there is a no gold standard treatment for staphloma, in spite of some methods are being done to monitor the progression of the staphloma, as many do not require treatment and remain stable over the time. But if we observe any thinning, we can do the posterior scleral reinforcement, and the options we can have that we can go for amniotic membrane graft, auto or homologous scleral patch either by rotational or pedicel scleral grafting or lamellar scleral autograft, and in the last we can have cadaveric scleral patch graft. Thank you so much.
Okay, Dr. Amna, good presentation, but you didn't look at the time. It was quite a lot you took. And because we have to calculate your journey.
Assalamualaikum, ladies and gentlemen. A very good morning to all of you. I'm Dr. Sana Chaudhary, 30 resident of ophthalmology, Jinnah Hospital, Lahore. Today I'm presenting a very interesting case of optic disc with maculopathy. I have no financial disclosures. So my patient was 37 years old male resident of Shalda. He presented to us with complaint of decrease of vision in the right eye from past 1.5 years. On taking further history, we found out that the vision loss was painless, it was gradual in onset and associated with distortion of images. However, there was no history of flashes, ocular pain, redness, or discharge. The left eye was perfectly fine. A patient gave history of subtenon Kenacort injection in the right eye 1 year back, and it was given elsewhere. Past medical history was not significant. Coming towards ocular examination, in the right eye visual acuity was counting finger and it got worsened with pinhole. In the left eye, best corrected visual acuity was 6/6. Anterior segment examination was quite normal in both eyes. On examination of fundus, in the right eye disc was round and however there was a cavitary lesion measuring 2/10 of the size of the disc diameter temporally, and there was decrease in neuroretinal rim, foveal reflex was altered and we could appreciate some macular swelling on clinical examination. Left fundus was healthy. Okay, this is the fundus photograph of the right eye of the patient, and this is showing macular swelling and optic disc temporally. In investigations, we performed OCT macula and we noted that there is macular schisis. The nerve fiber layer was intact. However, the inner segment outer segment junction was disrupted and macular edema is noted. So, on the basis of clinical examination and investigations, our provisional diagnosis was optic disc with maculopathy. So, in this patient, we performed a 3-4 23 gauge pars plana vitrectomy with ILM peeling, internal limiting membrane peel, and autologous serum. And the patient was closed with sulfur hexafluoride gas, and he was advised to keep his head down for 1 week. This is the actual video of the surgery which was performed in our theatre. So here a consultant surgeon is peeling ILM after staining it with brilliant blue. Here the autologous serum is being put on the optic disc. ILM peeling is further completed and you can appreciate blood clot on the optic disc bed, and this is done under air. And we close this patient in SF6 gas. So we followed up this patient after 3 months and 1 month after 1 year, and these are the OCT scans which were done at these follow-up visits. So as you can see, pre-operative, this is the pre-operative pre-operative OCT scan, and this is the OCT scan which was done after 1 year, and there is marked improvement in the macular edema, and the visual acuity of the patient improved from counting finger pre-operatively to 6/12 post-operatively. Okay, so what is optic disc? It is a congenital abnormality which is caused by incomplete closure of the optic nerve, with incomplete closure of the fetal tissue at the optic region, and there can be a visual deterioration if there is macular involvement, which can occur in 25 to 75% of the cases. And this macular involvement is characterized by accumulation of subretinal or intraretinal fluid. So this is a matter of great controversy. What is the source of this fluid? It can be vitreous, cerebrospinal fluid, blood vessels, or choroid to the Brooks membrane. So coming towards the literature search or studies that have been previously done, this is the study which is showing the pathogenesis of the optic disc with maculopathy. The initial approach, conservatively, we try to manage the patient conservatively, and we give oral steroids which can settle the macular edema. Laser photopropagation can also be performed, but these are less effectively, and we have ultimately go for surgery. So the pars plana vitrectomy is the mainstay of treatment so far. We can combine it with laser and gas tamponade and island peeling. Island flap has been introduced, and the patient can we can close the patient in sulfur hexafluoride gas or C3FA, and it will act as a temporary barrier. So the patient presented to us with optic disc pit maculopathy, and visual acuity of the patient improved from counting finger preoperatively to 6/12 post-operatively, and there was dramatic improvement in the vision of this patient, and the vision is stable so far. These are the references. Alright, thank you so much.
Okay, any question? Okay, Dr. Chana, what is the cause of optic disc pit?
So it is a congenital abnormality, and there is incomplete closure of the fetal tissue at the optic region. So it can cause optic disc pit, and there is a leakage of fluid from that pit into the macular area, which can cause macular species, macular edema, and ultimately maculopathy.
What are the causes of optic pit? What are the different types? How does it occur? What are the different routes of?
Sir, there are various ways for the fluid can come from vitreous, or it can come from cerebrospinal fluid, or it can cross from the forehead to the Brooks membrane or blood vessels.
What else would you include in the differential diagnosis?
So, optic nerve hypoplasia and morning glory syndrome. Thank you, sir.
Okay, good. Now is Komal Varis here? Okay, I'll call upon Komal Varis for her talk on a 1.6-year-old child with a red mark on her face.
Assalamualaikum. I'm Dr. Komal Varis from Pediatric Ophthalmology Department of Children's Hospital, Lahore. Well, today I'm going to present an interesting case of a 1.6-year-old child with a red mark on her face. She presented to us in emergency on May 25, 2022. She was a female. Her chief complaints was that there was a red mark on her face that was a port wine stain, and there was an increase in the size of her right eyeball. So as you can see in the picture, there is a red mark on the face. The history of presenting illness was that there was photophobia and nearsightedness, and that was associated with an increase in the size of her right eyeball, and it was not associated with any diurnal changes. Well, coming to the past history, the patient had a fever 4 days back that was accompanied with tonic-clonic fits. She was treated in the neurology department with an anti-epileptic drug as well as an antibiotic, and later on, when she was considered okay she was considered fit-free by the neurology department, she was referred to us for the eye examination. Her birth and developmental history was normal, and coming to the ocular history, there was no history of glasses, trauma, surgery, or laser. The clinical examination was alright, except for the port wine stain. Coming to the eye examination, her visual response of both the eyes were good. The eyelids of the right eye had a red mark, whereas that of the left eye was normal. The conjunctiva and the cornea both were clear. The pupils were round, regular, and reactive. The lens were clear, and extraocular movement of both the eyes were full. When her intraocular pressure was measured, the right eye was increased markedly, that was 30, whereas that of the left eye was normal within the normal range, that is 11. The axial length of the right eye was also increased, that was 21.65 millimeter, whereas that of the left eye was 20.91 millimeter, that was normal. The corneal diameter was slightly increased, that was 12.5 millimeter of the right eye, whereas that of the left eye was normal, that was 11. The fundoscopy was done, and that of the right eye showed a CD ratio of 0.4, that was increased, and whereas that of the left eye was normal, that was 0.2. We did the retinoscopy after dilation, and the myopia of -3 diopters was seen in the right eye, whereas that of the left eye was N2. So here are the pictures of IOP measurement, the corneal diameter measurement. So apart from these investigations, the EEG and CT scan was also done because the patient had a history of fits.
The EEG run shows no electrographic seizure activity, whereas the CT scan shows extraventricular CSF presence, and there was a hypodensity in the right posterior parietal and the temporal region with acute calcific foci. So the radiological examinations were also carried out because the patient was having fits, as I already mentioned. There was a leptomeningeal enhancement and pyeloangiomatosis, increased CSF spaces. Here are the pins of the CT scan. So, on the basis of all these investigations and the clinical examination, we made three differential diagnoses. The first one was a secondary glaucoma due to a systemic disease like Sturge-Weber syndrome. In this case, apart from that, it could have been a primary congenital glaucoma or a secondary glaucoma due to any other eye disease. So, we considered it as a Sturge-Weber syndrome. And the hallmarks of the Sturge-Weber syndromes are like there's a red mark on the face, large eyeball, history of fever, fits, raised IOP, and glaucoma. So on the basis of all these findings, it was considered Sturge-Weber. So coming to the management of the patient on the first visit was, as the patient had a raised IOP of 30, so we started tablet AZM, that is acetaminophen, and then that was given for 3 days along with topical beta blockers. It lowered the intraocular pressure to 28. On her second visit, topical beta blockers were continued and it lowered the pressure to 25. Whereas on the third visit, that was approximately 1 month back, the combination of carbonic anhydrase inhibitor and topical beta blocker were given for long-term use, and now the pressure of the right eye is 12 millimeter Hg, whereas that of the left is 11. So it is very much controlled. The CV ratio, however, of the right eye is 0.6, whereas that of the left eye is 0.2. So a patient is kept on follow-up for IOP and CDR measurement, and in order to track the effect of the pressure on the vision along with the neurological assessment. So this is how we manage the Sturge-Weber syndrome. Thank you. So here are the references.
Any questions for Dr. Kom?
How long you can patient on CAI?
Approximately for 1 year.
What's the mechanism? What's the mechanism of raise intraocular pressure?
In the raise intraocular pressure is caused due to three basic reasons. One is that the AC chamber is shallow in the case of the Sturge-Weber, in the Sturge-Weber disease, and apart from that, there is another problem. There is venous malformation, and there is a problem in the uvea as well as in this the uvea, and the uveal tract has some malformation due to which there is pyeloangiomatosis along with the uveal malformation, which causes high intraocular pressure in these cases.
Okay, what could be the findings in CT scan?
In the CT scan, there was increased CSF spaces. The choroid plexus was marked. The choroid plexus was very much prominent, and apart from that, a pyeloangiomatosis was also seen.
Okay, thank you, Dr. Komal. Is Dr. Usman should be there? Is Dr. Sana Ashraf here? Okay. She will give a talk on squamous cell carcinoma of eyelid. Dr. Hira Tanveer is here. No? Dr. Hira Tanveer. Okay, Dr. Hira Tanveer will give a talk on orbital cellulitis. Dr. Sana Ashraf, you will give afterwards? Yes, sir. Okay. He's uploading. Dr. Hira Tanveer for orbital orbital cellulitis you were talking about.
My name is Dr. Hira Siddiqui. I am first year resident of ophthalmology at Siemens Sherlock. A 46-year-old diabetic gentleman presented to us. A 46-year-old diabetic gentleman presented to us in the. So I'll start over. I'm Dr. Hira Siddiqui. I am president of ophthalmology at Siemens Sherlock. A 46-year-old diabetic gentleman from Lahore presented to us in the OPD with a complaint of swelling in the left eye for 1 day. The swelling was associated with restricted eye movements and proptosis. 1 week prior to the presentation, my patient had upper respiratory tract infection for which he was taking oral and intravenous antibiotics. He stopped these antibiotics after the due course, but 2 days thereafter he had sudden swelling of the left eye. The systemic review of the patient was non-contributory. The past history was significant only for diabetes for which he was taking oral hypoglycemic drugs. The clinical examination showed a normotensive patient with fever and tachycardia. The ocular examination showed the visual acuity of the patient to be 6/6 bilaterally. The near vision was N6 and the color vision on Ishihara tracking showed 17/17. The pupil was normal and brisk in the right eye but showed grade 1 relative afferent pupillary defect in the left eye. The extraocular movements were full for the right eye but showed restricted movements with variable diplopia in the left eye. The slit lamp examination for the right eye was unremarkable, with that the left eye showed adnexa to be edematous with proptosis and conjunctiva to have chemosis. Based on the history and the investigation and the examination of the patient, we made a provisional diagnosis of orbital cellulitis. Because there was diabetes, we also made differential of mucormycosis, preseptal cellulitis, and orbital tumors. The laboratory investigations showed the patient to have high basal blood glucose fasting levels. The differential leukocyte count was within the normal limits. The imaging showed the CT scan imaging showed mild retrobulbar fat stranding in the left eye and bilateral mucosal thickening in the ethmoid sinuses. The patient was admitted on the same day, and we started him on third generation cephalosporins intravenously, and for anaerobic cover we gave him metronidazole. For topical application, we gave him polyacrylic gel for lubrication and antibiotic cover of tobramycin ointment HS. We monitored his visual acuity, pupillary response for optic nerve monitoring, and we also sought consultation from otolaryngologist and medical specialist for treating his sinusitis and monitoring his blood glucose respectively. Patient showed marked improvement, as you can see, on the third day of admission and after initiation of the antibiotics. We discharged him on oral medication and called him back for follow-up, which showed complete resolution of symptoms. So, orbital cellulitis is infection of the soft tissue, which is lying posterior to the orbital septum. This is in contrast to the preseptal cellulitis, which lies anteriorly and often has a history of an event like bug bite or stye. The orbital cellulitis does not involve the group primarily and has the distinguishing signs and symptoms of ophthalmoplegia and proptosis. There is decreased vision if there is involvement of the optic nerve along with color vision and relative afferent pupillary defect. The cosmic organisms are gram-positive and gram-negative. In adults, it's polymicrobial, and in immune-compromised and diabetic patients, we often think of fungal culprits like Aspergillus and Mucormycosis. Other causes can include tooth infection, facial infection, middle ear infection, and we also think of trauma to the orbit in case of retained foreign body that is not responding to antibiotic therapy. So, for investigations, we go for a complete blood picture, which can often show elevated neutrophils and monocytes. Imaging studies, we go for CT and MRI. And the lumbar puncture is done if there is meningeal involvement, and blood cultures are done in case of septicemia. The diagnosis is based on imaging studies and multidisciplinary approach by an ophthalmologist, particularly an orbital surgeon and an ENT specialist is done. Empiric therapy with intravenous antibiotic is given. Typically, we give third-generation cephalosporins for anaerobic cover. We give metronidazole or clindamycin, and Vanco is reserved for cases with methicillin-resistant staph aureus. Surgical management may be needed if there is intracranial extension and abscess formation. The complications can be many, ranging from loss of vision and intracranial abscess formation and even death. In conclusion, a better glycemic control can prevent a myriad of complications. Thank you.
Thank you, Dr. Hiba. Any questions from the audience? Okay, what are the features of?
Oh, sorry.
Okay, what are the features of mucormycosis?
So it can basically infect the sinuses and it will cause extension to the orbit and it will cause the restricted eye movements, diplopia.
Specific?
So optic nerve involvement can occur.
Okay, how would you differentiate the orbital cellulitis from the preseptal cellulitis?
Now we can differentiate it on the basis of CT scan imaging. There is marked necrosis in case of orbital cellulitis. And there is often a history of preceding event like a stye or an insect bite or in preseptal cellulitis.
Clinically, actually, I was asking clinically, how would you differentiate between preseptal and
Extraocular extraocular movements are often clinical.
Thank you.
What is the source of infection in case of orbital cellulitis in younger children?
So, in 90% of the cases, it's often the underlying sinus infection, and it occurs mostly in winter season in male children, typically between the ages of 7 and 12, and the cause is sinus involvement.
Okay, thank you very much, Dr. Hira. Now we move to the last speaker, Dr. Sana Ashwin.
Bismillahirrahmanirrahim. Dr. Sana Ashwin, President of Ophthalmology at CMH Lahore. A 70-year-old female resident of Lahore presented to CMH Lahore with complaints of left upper lid swelling for the past 3 months. The swelling was painless and gradually increasing in size. There was no history of smoking or addiction, no significant past medical or family history. She was allergic to sulfa group of drugs and has a history of using topical drops. She has a long-standing history of vision loss in the right eye following pseudophakic bullous keratopathy. She is NPL in the right eye but has no past medical record available for the right eye, and she has only left functional eye. She has a history of blepharitis for which she has used topical drops, and she has underwent bilateral cataract surgeries and is using glasses for distant and near vision. There is no history of ocular trauma. General physical examination is within normal limits and cervical lymph nodes were not visible. Systemic examination is unremarkable. Vision in the right eye was NPL and in left it was 624, which improves to 615 with diffraction, and near vision was N12 in the left eye. Posterior segment examination of the right eye was not possible due to opaque cornea, and in left eye it was unremarkable. There was nodular ulcerative lesion. We can appreciate the notching of the lid margin and the loss of the eyelashes. So squamous cell carcinoma might be squamous cell carcinoma and it's nodular ulcerative or hyperkeratotic. And blepharitis is a chronic inflammation of the lid margins, but it's mostly bilateral and involves both the upper and the lower lids. Pigmented squamous cell carcinoma is a pigmented lesion with umbilical center, and less common causes include seborrheic keratosis, actinic keratosis, and keratocanthoma. So, a provisional diagnosis based on clinical findings is squamous cell carcinoma. Incisional biopsy report shows moderately differentiated squamous cell carcinoma, and we did excision of the tumor reconstruction using temporal forehead flap technique. It's particularly useful in monocular patients in whom occlusion of the eye or visual axis is not possible. With the procedures like Cutler-Beer procedure that involves closing the eye for almost 4 to 6 weeks. So excisional biopsy report shows involvement of both medial and lateral eyelid margins. These are the pre-operative pictures showing involvement of more than half of the upper eyelid. So posterior lamella was repaired using posterior lamella of the left eye was repaired using contralateral upper eyelid, and laterally the portion was taken from lateral periosteal wall and orbital periosteal wall, and anterior lamella was repaired. Anterior lamella was repaired from the ipsilateral temporal forehead flap. Donor side was sutured directly. These are the early post-op pictures, and these are 8 weeks post-op showing hypertrophy of the scar tissue that was explained to the patient previous to the surgery, and there was no leg of thermos or ptosis. Loss of eyelashes was also, and there was no eyelashes in the scar tissue, but it's barely perceptible. So squamous cell carcinoma is the second most common eyelid malignancy and second deadly skin carcinoma behind melanoma. It's there are high chances of metastasizing, and it's 2 times more common in male, more in fair-skinned people, and after the age of 40. Accumulated sun exposure over time is the single most important risk factor, and other risk factors include human papillomavirus, chronic skin wounds, and smoking, genetic predispositions of genetic factors like xeroderma pigmentosa, and history of previous skin cancer, fair-skinned people, and immune deficient people. It's multifactorial, and histopathy reports include prominent nuclei, reconstruction involves Cutler-Beer in thickness involving full thickness and area of the eyelid involving more than 50%, and temporal forehead flap technique. So initially follow-up is weekly for the first month, and then monthly for first year, and then 5 years, 6 months. And cervical lymph node examination is very important. So conclusion, as UV exposure is the single most important risk factor, so avoiding UV radiation or midday sun and using sun protective clothing, sunscreens is important. Second, the people who have malignant conditions or fair skin people or those having the history of previous skin cancer are counseled to visit the doctor if they notice anything new or changing or growing or simply not healing. Or as ophthalmologists, if patient present to us at the early stage, we are better able to manage the patient. Thank you.
Very good presentation, but you read a lot and you had a lot of slides and your time was a bit short, and in the end it's okay. Now, any questions for Dr. Sir? How will you differentiate between basal cell carcinoma and squamous cell carcinoma?
Clinically, there is loss of surface vessels in basal cell carcinoma. Nodulointegritias are present in basal cell carcinoma, and in squamous cell carcinoma, there is surface vessels are mostly.
Any other feature?
Ulcerative umbilical lesions based on the involvement of the upper eyelid or lower eyelid with gradation.
Good presentation. What is the incidence of squamous cell carcinoma?
It's almost 1% in Indo-Pak research. A research done almost 8 years back in
1% of all the tumors?
1% of the population, almost 1% of the population have the eyelid malignancies. Out of this 1% are the squamous cell carcinoma.
Okay, if we haven't got any questions, and we conclude this session. Is Dr. Ashwina Kayoo here? Okay, we conclude this session. Okay. Any comments, Dr. Tariq and Dr. Ashwin, last concluding remarks?
We have concluded that this is very well prepared. Your talks and your presentations were up to the mark, and keep this up and continue this. Although the topics were almost very common topics, there was nothing new or something out of routine. So these cases you have presented well. So continue this effort, and inshallah we give you your supervisors they need appreciation that you prepare so well. Thank you.
Madam President, it was a nice presentation. You well prepared and presented. Slightly कुछ लोगों को time management थोड़ी सी issue था, तो slide में जरा अपने आप को जरा confine करें time और थोड़ा सा इसमें जो एक तो presentation था, font बहुत छोटा था जरा थोड़ा सा उसको adjust करें, improve your presentation. Thank you so much.
I have a comment to make. वैसे तो जरूरत नहीं है. अस्सलाम वालेकुम. I'm Dr. Shabana and I'm leading consultant pediatric ophthalmologist Mia Hospital. I have a comment to make. Sorry for all the presentations were really good, up to the mark. ये हमारे youngsters हैं जिन्होंने आना है, हम लोग इनके role models हैं. I think the point I would suggest to the supervisors, they should support their candidates ताकि इनको कॉन्फिडेंस मिले और हम डायरेक्टली वो देखें कि अपने ये इन लोगों की हम प्रेजेंटेशंस कैसी हैं और उनमें जो लैग्स हैं, जो गैप्स हैं, वो ओवरकम करें ताकि नेक्स्ट टाइम पे जब ये इंटरनेशनल फोरम्स के ऊपर प्रेजेंट करें तो वो गैप्स ना हों. बट क्योंकि हम तो उनको अच्छा करके फीडबैक दे देंगे बिकॉज दोज आर कॉलीग्स और ये बच्चे भी दे देंगे. इन बच्चों को अगर हम ये कहेंगे कि आपकी ये गैप्स हैं तो इनका कॉन्फिडेंस शेटर हो जाएगा. तो हमें डायरेक्ट इनके सुपरवाइजर्स को बताना चाहिए था, लेकिन सुपरवाइजर यहाँ पे हैं नहीं अनफॉर्चुनेटली. कितने लोगों के हैं? There are only 2. सॉरी, मतलब मेरा तो फीडबैक ये है कि आप सुपरवाइजर्स को इन्वॉल्व कर रहे हैं, उन्हें कहें कि वो दे शुड प्रेजेंट हियर.
Very good point, Dr. Shabana. And we all encourage the youngsters because they will be coming and they will be replacing us in future, and very well done, and best of luck for your future. Inshallah, you will be a very good doctor.
And all the participants, they have already competed and they have topped their institutions as their best among the best.
Okay, with this we conclude the session. And the next session will be at 10:30. Now we will announce the result in the closing ceremony.
Okay, good luck everyone. Thank you so much.
These are done. Okay. क्या बदला? है प्याज. Okay. ऐसा देखो. ठीक है सर. ठीक है.
लंच के दौरान क्लोजिंग सेरेमनी के बाद
Is you doing the session? Don't tell them it's supposed to be a fourth year resident. This is you? We are on over your phone, then I'm on your phone.
नहीं आपको सिलेक्शन नहीं दिया इसके ऊपर सिलेक्शन मैं यहाँ से कर सकता हूँ क्वांटिटी यार थोड़ा छोटा नहीं क्वांटिटी ज़्यादा बड़ा
Oh, so you're doing the job stop at the don't you make the crossover and then you divide this into I think post orders and then some that you agree on that
I don't have sufficient data so it's that can be done easy
it's not
okay इसको चलाओ कैसे No, it's an original paper, but it has insufficient data to publish, you know. Sufficient amount of data to publish वो आपको sufficient ना हो तो हाँ पाकिस्तान में तो अभी मर्जी कर दूँगा अगर बाहर भेजने के लिए आपको quality data चाहिए होता है that's the problem so
Yes. Not just we think of it. I saw it. This is why they can do that all professional. It makes them opposite for just But I was starting because more
मुझे पंगा ना तुम्हारा हाँ गिरा ना सारा खोले लेकिन एग्जाम की शीट को देख रहा था एग्जाम की शीट कुछ कर रहा था साइड हो गया वो पावर कोई पावर यार अब तक लेकिन ले गया है वो सिलेक्शन जब मैंने वो शीट पावर पॉइंट को किया ना तो टाइम लग गया उसके ऊपर कर दिया और ये बड़ा है इसका साइज छोटा कैसे होगा ये टाइमर अब चालू है
अभी टाइम क्या है बता
10:26. 10:26.
Hello, testing 1, 2, 3.
स्टॉपवॉच होगी ठीक है काफी है बस कोई है आप में से कितने भाई की है चलो 5 मिनट वेट
ये आप लोगों ने जब पहले लगा दिया शुरू में ये भी बोल रहे हैं शुरू कैसे
बस अभी को सफेद कर दे
अच्छा मैं भी गिरा अच्छा
Okay, Bismillahirrahmanirrahim. We are going to start a free paper session 4 for the residents, and Dr. Rehan Nikash is here.
Yes.
Okay. What first I want to tell you candidates that there are 6 minutes allocated. 5 minutes after 5 minutes, we will give a ring, and you are supposed to finish your talk within 5 minutes, and 1 minute is reserved for question answers. Okay, and if you exceed that, then we will obviously deduct marks for that. Okay, okay, and Dr. Rehan Nikash will come for his talk on comparison of two-hole assisted phaco chop with stop and chop technique for nuclear disassembly in villages. Dr. Rehan Nikash.
My name is Dr. Namakesh. I'm from Shifa Trust, Rawalpindi, and today I'm presenting a comparison between two-hole assisted phaco chop and the stop and chop technique in residence cataract surgery. So, yeah. So since cataract surgery is one of the most commonly performed surgeries worldwide, and since Dr. Kelman introduced ultrasonic phacoemulsification in 1967, it has evolved. Currently, cataract surgery, there are many techniques to do nuclear disassembly, which is one of the most important steps of cataract surgery. Gimbel introduced the divide and conquer technique in 1991. Nagahara followed this by the concept of phaco-chop in 1993, and Wolfcock merged between the two and published his radiation in 1994. So this is the divide and conquer technique. You make two trenches perpendicular to each other, and then you place the fourth instruments deep into the groove, and then you crack the nucleus. The direct chop technique introduced by Nagahara, we basically embed the phaco probe in the center of the nucleus. The chopper is taken beneath the rhexis to the equator, and then the chopper is brought towards the phaco probe, and then lateral separation maneuvers are done. Scott merged between both of the two. He made a central trench, divided the nucleus, and then he divided the heminuclei by the direct chop technique. The phaco-chop by Nagahara has many documented advantages. There is reduced sonorous stress, there is reduced ultrasound energy, but the drawback is that this technique has a higher learning curve, and it's a bit risky. The risk for novel surgeons, why they shy from this technique, is that they can either cause the intracapsular tear while they're taking the chopper beneath, and if they place the chopper above the rhexis margin and then pull, then they can cause zonar dialysis in that quadrant. In 2021, Miyamoto reported a new technique for residents who want to shift from the trenching techniques to the direct chop. He created a technique that allows the residents to perform the horizontal maneuvers while staying within the rhexis margin. So what he proposed was to drill two holes within the rhexis margin, place the chopper in one of the holes, the phaco tip in the other, and then join so that the resident can learn the horizontal maneuvers while staying within the rhexis margin. Our research question was, can this technique allow the residents to do a safe and effective surgery, and that will help them to transition from trenching to chopping techniques? Our objective was to compare two different nuclear fracture techniques, the two-hole assisted phaco chop and the stop and chop performed by a single resident. This was a randomized control trial from the Chapatistai Hospital. 30 eyes were divided into both groups with randomization by the random generator, and convenience non-probability sampling was used. We included patients between 20 to 70 years with no gender predilection and only nuclear sclerosis grade 2 to 4. Soft cataracts and hypermature and complicated cataracts were excluded from our study. All surgeries were performed by a single fourth-year resident under supervision of an attending surgeon. We measured three variables: the ultrasound time, the total surgical time, and the BSS. The operating device was the Catrax Easy, and this is a video. Please play the video. So we first begin by constructing a triplanar 2.75mm incision. Then we inject the dye, and after the dye, we create a adequate size rhexis. We need a large rhexis for this above between 5.5mm and 6mm, because the maneuvers are done sub-incisionally and we need good rotation. So this makes, if the rhexis is small, this won't be safe. This is the anterior cortex removal. Then we drill the first hole sub-incisionally. The hole should be deep enough so that the chopper can be placed carefully within this. This is the first hole. After we drill the first hole, we rotate the nucleus opposite 180 degrees to the other equator. Then we drill the second hole. So these maneuvers are done in high power and low vacuum. We hold the nucleus. The chopper is brought toward the phaco probe and then cracked. The rest of the cataract is then emulsified by the standard chopping techniques. This is the stop and chop technique. The results show that the mean difference between the two hole and the stop and chop are clinically insignificant by the independent t-test. This means that this technique is a safe and effective technique. It's non-inferior to the stop and chop. The nuclear sclerosis and the variables show that this was clinically significant by the ANOVA in SPSS version 28. So Miyamoto described this technique in 21 last year, and he compared this technique between residents divide and conquer and this technique. Our study was between the stop and chop and the two-hole assisted chop. Our conclusion is that this is non-inferior to the stop and chop technique. Residents who want to transition from trenching maneuvers to chopping maneuvers can use this technique effectively and safely, and can inculcate this in their arsenal of techniques for cataract surgery. Thank you.
Very good technique, and questions open. Next question. Okay, how many cases did you do?
So we did 30 cases, 15 of stop and shop, 15 of two-hole assisted take job.
Okay, and you graded from the grade 2 to grade 4?
Yes, sir.
And how many grade 4 cases?
Sir, around, I think 5. I have these data with me. I can show you. Around 4 to 5.
Okay. Okay, and was there any problem with grade 4?
So we did not move from grade 4 above. So there was the cataracts we chose did not have a leathery plate. So the tracking was done comfortably, and we basically included parallel complications in the exclusion. So in our 30 cases, we did not have any complications. So our case selection was very important. We did not include complicated cataracts, hypermature cataracts. We only included the cataracts we knew they could be safely performed.
Any questions for Dr.?
Yes.
As you mentioned the age of the patients, it was ranging from 20 to 70 years.
Yes.
And you have excluded the soft cataract as well.
Yes, yes.
So, what was the cataract of 20 years age patient or 25 years age patient?
Most of our patients were above the age of 40. That was just in the inclusion criteria. But our data had around 50, and because nuclear sclerosis obviously grade 2 starts around 40 to 50. Yes.
Just for clarity, you said cut-off complications were excluded from the study?
So we do not have any complications, but in the exclusion criteria, if there was a cut-off complication, which can happen in cataract surgery by any surgeon, especially residents, we had planned to exclude them from the study. And for example, if there was posterior capsular rent, or there was some problem during hybridissection, capsular blowout.
So wouldn't that cause some kind of bias in the study?
So that you can quote that these complications occurred in the study, but the data collection would not be what can
affected by it.
Yes, yes.
So, complications of both groups were excluded.
Yes, yes, complications of both groups. So because this was added because these surgeries were being performed by residents, by the senior residents, under the supervision of senior consultants. So complications can happen by residents during cataract surgery. It's not uncommon.
Okay, thank you, Dr. Rizwan.
Thanks.
Now I'll call upon Dr. Adnan Abdul Majid to present a rare case of pachydermoperi-ostosis and its ocular manifestation.
First. Sorry, my name is Dr. Adnan Abdul Majid. I'm FCBS resident at Civil Institute of Ophthalmology and Medical Sciences. Today I'm here to present a very unique case. There are no financial disclosures. These are the learning outlines of my presentations. History. There was a 50-year-old male presented in the outpatient department with a complaint of heaviness of the both eyelids since 20 years and a turning outward of the left lower lid since 3 years. On systemic evaluation, the patient has a history of joint pain, especially at knees and ankles. And his family, his nephew had a similar complaint. He is a child of consanguineous parents. On physical examination, as you can appreciate, there was a pachyderma of the skin of forehead and the scalp, deep forehead furrows, oily skin, excessive sweating on the palms and soles, hands and foot were enlarged. There was a grade 4 clubbing in the foot and toes. As you can appreciate, there was a grade 4 clubbing in the hands and the toes. Also, there was a similar feature of a clubbing, and there was an ankle joint swelling. On ocular examination, there was a bilateral blepharoptosis with -2 MRD in both eyes. Levator function was poor, and Patient used predominantly frontalis muscle to open his eye. The extraocular movements were normal. The eyelids were thickened, enlarged, and the floppy. Eyelids could be easily pulled away and averted. There was lid laxity and the left lower lid ectropion. Patient vision was decreased because of significant cataract. Investigation we have done was the eyelid skin biopsy. Over there we found a non-specific inflammatory and the foreign body giant cell, sebaceous gland hyperplasia, and there was a few dilated periosebaceous ducts and double edema mostly in upper dermis. We also did X-ray of this patient and we found that there was acro-osteolysis, which is the reopening of the bone of the distal phalanx, and there was a periostosis, which is subperiosteal new bone formation. And also you can appreciate there was a soft tissue edema. So our diagnosis was pachydermoperiostosis, which is also known as the multiple nerve, which includes primary or idiopathic hypertrophic osteoarthropathy. So management we have done for this patient was the left lower lid wedge resection, which was for the correction as well as for the biopsy, and we later on trained for the LTS for the left eye. Patient was referred to the rheumatologist for further management. So what is pachydermoperiostosis? This is basically a disease of the skin and the bones, which is characterized by three main features, which includes the pachyderma, which is the thickening of the skin, periostosis, the new subperiosteal bone formation, and the digital clubbing. There are three types: complete, having all the features; incomplete, having the periostosis without pachyderma; and the form first with the pachyderma with minimum or no at all periosteal involvement. Epidemiology: the first case was reported in 1968 by the Frederick. Only 204 cases were reported. Our case was 205th case we reported. And the Pakistan in ophthalmology, the male to female ratio is 9 to 1, and their precise incidence of prevalence is still unknown. And pathogenesis, actually there is no specific or the exact pathogenesis known, but there are two theories. One includes the humoral theory, which is the most accepted theory, which includes the blood mediators, including prostaglandin E2, which is responsible for the pathogenesis. What prostaglandin E2 causes the fibroblast proliferation, and which lead to the pachydermoperiostosis. The similar role of prostaglandins. Ocular manifestation include the blepharosis, floppy eyelid syndrome, hypertrophy of the eyelid and the palpebral conjunctiva, mechanical ectropion, Neubergen gland dysfunction, tear film abnormality, punctate apical erosion, and ocular surface disease. So the take-home message is evaluate and treat the patient as a whole, not just the eye. This was the case report we just reported in September 2022. These were the references of my talk. Thank you very much.
A very good talk. How to open for this? Okay, we move to the next speaker, Muhammad Nasir Khan. Is he here? No. Okay. Adnan Abdul Majid for his talk on von Hippel-Lindau syndrome.
Assalamu everyone. As you know, my name is Dr. Adnan Abdul Majid, FC President SRPS. Today I would like to present another unique case. There were no financial disclosures. These are the outline of my cases. Case number 1 is a woman aged 20 years presented by chief symptom of left eye, gradual painless loss of vision since 3 years. And there was a left eye, there was a pain since 6 months. Past history was she had a left eye prior lesions 4 months back. The family history, she had a one brother and one sister, both are healthy, and the rest of the history was not significant. On slit examination, the only positive finding in the right eye was in the mid-periphery, in the fundus examination, in the retina mid-periphery, there was a multiple red lesions. In the left eye, the vision was NPL with a pressure of 38 mm of mercury, and cornea was slightly hazy, and the iris was having an ectropion uvea, and both vitreous and fundus view was not clear. This is the picture on the left hand. You can easily appreciate the congested conjunctiva and the ectropion uvea and dilated fixed pupil with few new vessels in the iris. This was the fundus view of the left of the patient. Despite the view is not clear, but you can easily appreciate there are multiple red lesions over here and with exudation. And this was the fundus picture of the right of the patient. The fundus was almost normal, but the periphery that you can appreciate there's a circular reddish orange lesion in between the superior and inferior temporal arcades, and also the superior quadrant of the retina. Investigation we want for this patient was FFA, MRI gradient contrast CT scan abdomen. And the FFA you can easily appreciate the same red lesion which was previously shown having a hyperfluorescence at the early stages of the FFA. The similar stage picture with a more brightness, and this is the late leaking off from the same lesion. MRI report was almost normal. CT scan abdomen has shown us multiple cystic lesions in the pancreas. So the summary of my patient was the left eye was a painful blind eye with the right eye having a multiple capillary hemangiomas. CT scan abdomen shows that the pancreatic cyst. So our diagnosis was von Hippel-Lindau syndrome. Also in the eye there was a retinal capillary hemangioma. So management we have done. Right eye we have done the argon laser photocoagulation for the region. Left eye was treated with a painful blind eye. You can appreciate the fundus picture before laser. These are the regions, and after laser you can easily see there's a gradual resolving of the regions, and also the vessels are being more straight and normalized as per the normal fundus. Case 2 was a 40-year-old male, decreased vision, right eye since 3 months, preceded by the redness and the pain. The positive finding in the right eye was the endothelial dusting and 360 costis anarchy, and the lens was cataractus. Rest of the examination, both eye was normal. You can easily appreciate in the right eye the vision was PLPR, and the finding previously told, you can appreciate it here. This was the picture of the right eye. The view was hazy. Despite of that, you can appreciate there is a dilated red vessel, tortuosity on the vessel, and exudation of the vessel along with the vessels. This was a picture of the left eye. You can easily appreciate this is a particular finding. You can see that the feeding vessel, red, dilated, thickened vessel is associated with exudation, and the far periphery you can appreciate the red, circular orange lesion. This was the FFA showing the late leaking. The system investigation was normal. So these were the definition, but more likely this was the retinal capillary hemangioma. This was a von Hippel-Lindau disease. This was a disease because it was not associated with any systemic finding. The previous case was a syndrome, von Hippel-Lindau syndrome, because it was associated with the systemic finding. Von Hippel-Lindau syndrome is a phacomatous with the multi-system involvement, multiple cysts, visceral cysts, which are benign tumors which have potency to go malignant transformation. It is because it is mostly autosomal dominant inheritance with about 20% sporadic, caused by the mutation in the tumor suppressor gene, VHL gene, which is present in the chromosome number 3. These were the manifestation. Retinal capillary hemangioma occur from 60 to 70% of the patient with a CNS tumor, kidney tumor, adrenal gland tumor, and other visceral tumors. So these are the classification and also the grading, and the fourth stage, the last stage, you can say uveitis. So our case was having a uveitis associated with the retinal capillary hemangioma. He was a diagnostic criteria. Management depends upon the size and site of presence of the complication. We can observe if it is asymptomatic or juxtapapillary. Laser photocoagulation at the region at the periphery at less than 3 mm, and cryotherapy its periphery but large, associated with a subretinal fluid. Brachytherapy, region too large for the cryotherapy, and PDT for just juxtapapillary tumor. Anti-VEGF if it's an extrapyramidal tumor. Also, there is an important thing, intravitreal propanol has been under investigation, under trial, but it has provided us a very good results. Via surgery, we can do for the complications. The take-home message is we need to associate every finding of the eye with the systemic involvement. As in this case, the patient was a marital capillomania, but we have gone for the systemic investigation and we have saved the life of the patient. These are the references of my talk. Thank you very much.
Any question for Dr. Adnan?
What parameters did you know for the laser photocoagulation?
So actually, this was a far periphery and small lesion. That's why, sir, we have gone to the laser photocoagulation.
So parameters.
Yes, sir. It was low power and high frequency laser, argon laser we have provided. Around first of all, what we do, we have targeted the vessel. When the vessel is obstructed, shrinked, then the tumor itself dissolves. But if it's not resolving, then we can photocoagulate around the periphery of the lesion, and then it will automatically resolve.
Thank you very much. Now we go on to another speaker. It's Faraz Munir. He will talk on evaluation and monitoring of phacoemulsification skills of postgraduate residents by adopting a standardized International Council of Ophthalmology Surgical Competency Assessment.
Bismillahirrahmanirrahim. Assalamu alaikum to everyone. The most common surgical surgery done by residents is phacoemulsification. So today my topic is about, is there any standard or criteria which we are following to check how we are performing the surgery and which step we are lacking, or if we are just doing just as a standard trial and error method. So the standard which we should follow for phacoemulsification is given by International Council of Ophthalmology. This is developed in 2013, and it is called as International Council of Ophthalmology Surgical Competency Assessment Review. And this criteria has divided phaco into 20 steps and graded from novice to competent, and it denotes like 2 to 4. It has been graded from 2 to 4. Novice means the beginner has just started, and 3 means beginner, like resident is in the early stages. Advanced beginner means that he has improved something, and competent means that he has fully progressed with study. Now these are the 20 different steps in which the system has divided the phacoemulsification surgery, and this is the detail according to which we grade different, like this is the novice 2, 3, 4 and 5, and these are the 20 steps, and every step has a detail that how we will classify who is the beginner and who is competent. And just as a practice, we will consider only one step here so that just I can explain the procedure. Like step C, phaco insertion. Like how we insert phaco entry. So these are the 4 grades which the system has done. So if a resident can insert the phaco probe with some difficulty and can damage the wound or cornea, so he will be level 2. And if he can enter the phaco with multiple attempts and can damage, there is a probability that he can damage the cornea, so he will be graded to 3. And if he can do with mild difficulty and no wound damage, then he will be graded to 4. And if he can do easily and there is no wound damage, so we will level him 4 5. So like this we have calculated 4 steps of all residents. And purpose of this study was to monitor and improve skills of PGR. And study design was prospective observation study. And we have done this in our department, Unit 1 hospital, for the duration of 12 months. And the inclusion criteria was like only residents did this, like not SR or seniors did this, including this. And exclusion was patients with only eye and patient having any ocular comorbidity like uveitis or phacotomesis or supraexfoliation. So data is collected like every trainee has done his phaco surgery, and after surgery he has moved to his supervisor and note down his steps and graded the steps. Data analysis was done by SPSS 126. And now we will discuss the results. Like in the trainees, 7 trainees were male and 9 were females. And if you talk about, there were like 47% were fourth year residents and 53% were the third year residents. So here we can say this is the learning curve for the third year resident. We can say there was a progression. These are the months. There was a progressive improvement in the third year residents, and as the fourth year residents are already like seniors, so they improved much sooner. And this was according to gender comparison. And this was a comparison of third year and fourth year. And this was we can see this orange lines denotes the level of the trainer resident in the start, and this brown line denotes the level in the end. So we can see in the beginning some residents were 3, some are at 2, but in the end most of them reach the 5. And from this method we can also assess that some residents lag behind, so we can assess that these residents need more attention and more practice. So the conclusion is that we should adopt this method for residents so that they can know which steps they are lacking and which step they have to improve. So I want to thank my seniors who helped me in this project. Thank you everyone. Any questions?
ये असेसमेंट कैसे कर रहे सुपरवाइजर कर रहे थे वहाँ पे आपकी या पीजीज कर रहे थे लाइव सर्जरी पे कर रहे थे या वीडियो
सही सुपरवाइजर के साथ ही हमारे थे जो रेजिडेंट सर्जरी कर रहा था वो सुपरवाइजर के साथ ही फिर वो उसी सर्जरी के एंड में उसको ग्रेड करते थे कि सुपरवाइजर देखा अगर हमारी इनकी एसिड लगी हुई है उस पर रेजिडेंट उससे भी देख लेते थे तो इस ट्रेक का लर्निंग इम्पोर्टेंट.
Okay, thank you very much.
Thank you.
Now we move on to the speaker, another Ashwina to you. Okay. Her talk is on ocular findings in children with developmental delay.
Assalamualaikum. My name is Ashwina Siyam and I am a graduate of CMH College, Lahore. So, my topic was ocular findings in developmentally delayed children. I would like to start with a story. Recently, I overheard a conversation between my mother and her friend. So, the gist was that her friend was looking for an organization where her house help could check in her child because her child was developmentally delayed and she thought that she would not be able to take the responsibility. In Pakistan, developmental delay is a huge public health concern because families perceive these children as a burden to them. Hence, they're not sent to schools, they aren't encouraged to go out of houses and contributing to the cycle of poverty. Unfortunately, in Pakistan, we don't have any national database for developmentally delayed children, but data from other similar countries like India or Iran shows that at least 10 to 15% of children undergo developmental delay, and at least 45% of them have ocular problems. Uh, despite that, uh, visual problems are really ignored by the parents and the ignored by the parents as well as the healthcare providers, because developmentally delayed children have such serious illnesses and require such intensive care that that visual delay is actually secondary to those. But even though visual assessment is actually very important in these children, because a good visual development is important not only for is important for gross fine motor development, for facial recognition and building social relationships between the child and its families. Hence, it is imperative to have. Hence, it is imperative for a proper visual assessment, and it is imperative to know the visual milestones. It is imperative to know the visual milestones in these children, which include eye contact at 8 weeks, social smile at 3 months, awareness of hands at 3 months, and so on and so forth. So our study was a cross-sectional observational study at 2 centers at Children's Hospital Lahore and Children's Eye Care Clinic in Lahore. Duration was 2 years, from October 2020 to October 2022, and 106 developmentally delayed children who were assessed by a developmental pediatrician and referred to the pediatric ophthalmologist were included. So a detailed history and examination was done, visual acuity, and according to age was done visual acuity, measurement of deviation in case of squint, and retinoscopy, cycloplegic refraction was done, as well as slit lamp examination. This males were 63% and females were 37% in our study. The age distribution was 1 to 2 years, had the highest amount of children, and 60% of our children had an ocular problem, and this was in line with other studies that were done in other countries, not in our own. Nystagmus was the commonest finding, and refractive error, 30% of these children had a refractive error, and hypermetropia was the commonest, with 70% of these children having it. In squint, exotropia was the commonest. And if we compare nystagmus with visual delay, hyperopia was the commonest ocular problem in both of these. Comparing these with other studies, ocular involvement was seen in 70%, and it was similar to other findings, which had 83% and 77%. Refractive error was the commonest in ours as well as the other studies, and followed by squint. In our study, exotropia was the commonest. So, to conclude, this visually challenged infants have poor or absent accommodation with or without hyperopia have such blurred vision that they develop poor eye contact. This can be actually misdiagnosed with autism, because the poor eye contact causes them to have autistic-like behaviors. So it's important for development to assess developmentally delayed children at every step of the way, because these children, if they have a compromised vision, can lead to a compromised life. Thank you.
Any questions for Dr.
आप कोई क्वेश्चन करें
If I will ask a question, you will know the answer.
So what was the age group which you studied? For which?
So most of the children were less than 5 years of age by coincidence, because when the child is 1 to 2 years of age, the parents are more panicked, so they tend to bring their children more highly. So if in more than 5 years of age, you don't really tend to see these ocular anomalies as often, and these children are most oftentimes ignored because you don't think that's important enough, especially in developmentally delayed children. They have much more serious problems that they look at.
What type of refractive error did you find?
Hypermetropia was the commonest.
Okay, any questions? Okay, thank you, Dr. Ashwin. Now we move on to Dr. Mehmoona Rafi for a talk on comparison of the intraoperative safety, efficacy, and post-surgical outcomes of coaxial and bimanual irrigation aspiration modalities in phacoemulsification surgery.
Assalamualaikum. I'm Dr. Mehmoona Rafi, currently working as postgraduate resident in our hospital, Lahore. The topic I'm going to talk about today is comparison of the intraoperative safety, efficacy, and post-surgical outcomes of coaxial and bimanual irrigation aspiration modalities in phacoemulsification surgeries. Starting with the introduction, irrigation and aspiration are the crucial steps in the phacoemulsification as it helps in maintaining the constant fluid dynamics in NTA chamber, preventing tissue damage and minimizing the heat production. Irrigation aspiration modalities basically include manual technique via Semco cannula, coaxial and bimanual handpiece. In bimanual micro incisions cataract surgeries, two separate handpieces are used for the process of irrigation and aspiration via two separate ports that are conventionally made at 3 and 9 o'clock positions that are usually of equal sizes and interchangeable. Whereas in coaxial micro-incision cataract surgery, one port functions for both irrigation and aspiration but involves larger single port. I have defined the terms in my topic by the following parameters: safety as like incidence of intraoperative complications, efficacy by the parameters like duration of the surgery, size of incision, and outcomes via postoperative visual acuity, NTA chamber reaction rate, and corneal integrity. The objective of the study was to compare the intraoperative safety, efficacy, and post-surgical outcomes in patients undergoing cataract surgery by one of the two modalities of irrigation aspiration and phacoemulsification. The study design was prospective, randomized, controlled, design, single-center interventional study that was carried in Institute of Ophthalmology, Unit 3, Mem Hospital, Lahore. All surgeries were performed by same surgeon using same phaco machine in same operation theatre. It was carried during a period of 6 months from March to August 22. Sample size was total 90 patients were included that were divided into 2 groups of 45 each. And sampling technique was convenient sampling. Patients including in the study were those with immature cataract or nucleus necrosis from grade 1 to 3, age between 20 to 70, normal adnexa, orbital intraocular contacts, and topical anesthesia was used for surgery, while excluding the patients with traumatic and mature cataract with any other ocular abnormalities, with a known case of glaucoma and known case of hypertension and glycemic for a prolonged period of time. Data was collected by using intraoperative parameters using a questionnaire that were answered by the surgeon, and postoperative parameters were filled on first post-op day and first week follow-up visits in OPD, assuming patients with compliance to medications and general precautions. Snellen chart was used to assess visual acuity, and detailed slit-lamp examination of the anterior and the posterior segment was performed. Statistical analysis was done using SPCS Meridian 25, and test of distributions were performed. Demographic data was as total 90 patients were included, divided into 2 groups, 45 for the coaxial, 45 for bimanual. In order to reduce the incidence of the confounders, we selected the patient as if they have nearly equal percentages for the male and female in each group, and mean age was 54 in coaxial group and 56.8, just to reduce the confounders. Preoperative assessment parameter that I have discussed in my research is grading of cataract, and you can see in both groups, majority of the patients included were having NS plus 2 grade. And intraoperative factors, factors we studied were final ACL, volume of total fluid use and duration of surgery. And bimanual group of the patients, these parameters were incision size was smaller and volume of fluid use was less and duration of surgery was less as compared to coaxial group. Complications were there as they are inevitable, and the incidence was much less in bimanual group as compared to coaxial. Postoperative factor, corneal edema was studied on the first post-op day and the first week on the first visit in OPD. And initially there were only 15 patients in coaxial group that were having clear cornea, whereas in the bimanual group 23 patients were having clear cornea. And MTA chamber was quite no AC reaction was seen in the majority of the patients in bimanual group as compared to coaxial. So the outcome in utilization were bimanual technique of irrigation aspiration enables the surgeon to perform cataract surgeries in less time with low risk of intraoperative complications and better surgical outcomes. There were limitations. Results can be made more significant by using more variables like estimated phaco time, postoperative best corrected visual acuity, and degree of astigmatism. I acknowledge my mentors, Professor Dr. Zahid Kamal, Professor Dr. Asad Numan, and Dr. Shabana for helping me. And thank you.
Okay, very good presentation, but time was limited. We exceeded it. How many cases did you present?
So there were total 90 patients. We divided them into two groups of 45 each. 45 for coaxial, 45 for bimanual.
And was there same surgeon or different surgeon?
Same surgeon, same machine, and same operative setups.
Genders
So genders जो थे that were जो मेल और फीमेल्स के हमने ऑलमोस्ट इक्वल रखे थे. एक में 60% मेल्स और एक में 56%, ताकि वो भी ज़्यादा मतलब ना आए. और जो हमारे ग्रेड्स थे वो भी NS+2 मोस्टली.
Okay, any questions for Dr. Mehmood? Okay, thank you very much. Now we move on to another speaker, Dr. Azam Mughal. Is he here? Yes. His talk is on diagnostic accuracy of direct ophthalmoscopy and non-myopic retinal photography for treating of diabetic retinopathy.
In the name of Allah, the most beneficial and the most merciful. Hello everybody, this is Dr. Azam Mughal, resident at Al Ibrahim Eye Hospital, Isra Postgraduate Institute of Ophthalmology, Karachi. Today I am going to present a paper to determine the reliability of direct ophthalmoscopy and non-myotic fundus photography for screening of diabetic retinopathy. As you all know that the diabetic retinopathy is classified into non-proliferative diabetic retinopathy, proliferative, and the clinical significant macular edema. In worldwide, there are approximately 93 million people with DR. From them, 17 million have PDR and 21 million have diabetic macular edema. In Pakistan, at least 90,000 to 100,000 adults with vision-threatening diabetic retinopathy. In order to prevent progression of DR to vision-threatening diabetic retinopathy, all the non-diabetics should undergo annual DR screening as per recommendations. Non-myotic fundus camera has been recommended as a useful tool for mass screening. The cost and maintenance prevents its use in a resource-strained country like ours. Direct ophthalmoscopy in the hands of well-trained optometrists might be a cheaper method. International standards of more than 80% sensitivity and 90% specificity has been declared. Materials and methods, it was a comparative cross-sectional study was carried out at Diabetic Eye Clinic of Al Ibrahim Eye Hospital, Karachi. The duration of the study was from October to December. All the newly registered type 2 patients with diabetic mellitus type 2 of age more than 40 years of age, irrespective of gender, were included. Exclusion criteria type 1 and gestational diabetes, and all the patients were examined for routine basic eye examination like refraction, best corrected vision, and that the data was entered into the database. The optometrists were instructed to identify presence or otherwise of the diabetic retinopathy based on the presence of hemorrhages, exudate, or blood vessels changes, and macular edema. All the observers were unaware of the results of others. So here, first of all, the patient comes in OPD, and then he goes to the optometrist one who examines the patient with non-myotic fundus camera and record findings. Then the patient goes to the second optometrist after pupil dilation, which examines the patients with direct ophthalmoscopy. And then the patient goes to the ophthalmologist, which examines the patient on slit examination with 90-day lens, which was reference finding. And these are the results of our study, which shows that the diabetic retinopathy detected in 19% of the eyes through non-myotic fundus camera, and 16% of the eyes with direct ophthalmoscope, and 21% of the eyes with slit lamp. The number of patients was 698. Number of eyes was 698 to 349 individuals. This is the chart of sensitivity and specificity. The sensitivity of non-myotic fundus camera was 76%, while that of direct ophthalmoscopy was 64%. Specificity was 97% with NMFC, while 96% with direct ophthalmoscope. This study showed improvement over figures of previous studies that were 72% sensitivity and 86% specificity. It supports the digital photography with NMFC as a usual tool for mass screening. Direct ophthalmoscopy by an optometrist can be most cost-effective tool, especially in community screening and primary eye care centers. The present study has shown that direct ophthalmoscopy in the hands of optometrists had sensitivity of 64 and specificity of 96%. The studies from UK have shown sensitivity levels of the detection of sight-threatening diabetic retinopathy of 40 to 70% for general practitioners, 48 to 80% for optometrists, and 60% of an ophthalmologist. So the conclusion of our paper or study was the digital photography with non-myotic fundus camera is promising screening method where trained ophthalmologists are not available. Direct ophthalmoscopy in the hands of a well-trained optometrist can be depended upon in the primary care setup and in a community where neither ophthalmologist nor non-myotic fundus camera is available. In the end, I thanks, and this is my logo of my parent institute, and if you have any question regarding it, you can ask. Thank you.
Dr. Asif, you come from Karachi.
Yes.
What do you recommend there? Direct ophthalmoscopy or non-pediatric?
Sir, non-myotic fundus camera is superior to ophthalmoscopy if the examiner of direct ophthalmoscopy is untrained and skillful. But if he or she is a trained retina specialist, then he or she can give more and exact findings on direct ophthalmoscopy than the non-myotic fundus camera. This camera is basically for optometrists or technicians for a mass screening where neither ophthalmologist or trained optometrist is not available on those areas. But the cost is little bit cost.
Fundus camera की जो photograph हुआ analyze how it
ophthalmologist, retina specialist. ऑप्थेल्मोलॉजिस्ट जो ऑप्टोमेट्रिस्ट जो कैमरा से पिक्चर ले रहा था और डायरेक्ट ऑप्थेल्मोस्कोपी से स्क्रीन कर रहा था, so they were unaware of each other finding. But after that, the ophthalmologist who is examined on 90-day examination, he set the reference findings and he assessed the finding of camera and direct.
Same patient was followed at 3 steps.
Yes.
So after the following ophthalmologist, how the accuracy of the direct ophthalmoscope was?
Sir, it shows a sensitivity of more than 70% and a specificity of 96%. It means that if a patient is examined, if 100 patients are examined on direct ophthalmoscopy and non-con, that the optometrist may miss the 24 to 25 cases and may misdiagnose 4 cases with direct ophthalmoscopy.
What do you think if in the remote area where is you have the ophthalmoscope direct, but there is no any ophthalmologist, how you?
Then this fundus camera is useful for screening of that remote area.
But the optometrist can refer the patient.
Yes.
He can diagnose and refer the tertiary care hospital.
Yes, exactly.
Thank you.
Okay, thank you very much.
Thank you.
And we have got a last speaker, but I think he's here or not. Dr. Norm Zoyan. So we conclude this session of free paper, resident free paper 4, and after 5 minutes we will be starting the next session. Thank you very much. The results will be displayed in the grand hall after this, because we have to compile the results of all